Good evening, everyone. My name is Ashley with RBC Consultants. We are excited to bring to you tonight's IDEF Educational Series webinar. The title of tonight's talk is Mild to Moderate Atopic Dermatitis, Burden of Disease and Topical Pathway for JAK Inhibition. As moderator tonight, we have Dr. Leon Kircik. He is president of the International Dermatology Education Foundation, clinical professor of dermatology, Icahn School of Medicine at Mount Sinai in New York, New York, Indiana University Medical Center, Indianapolis, Indiana, and medical director of physician skin care, derm research, and skin sciences, all in Louisville, Kentucky. As speaker this evening, we have Dr. Matthew Zerwas. He is Director of Clinical Trials and Dermatitis Center, Bexley Dermatology in Bexley, Ohio. He's founder of Bexley Dermatology Research Clinic, Adena Regional Medical Center, Columbus, Ohio. We would like to say thank you to our supporter this evening, Incyte Dermatology, for making this educational event possible. Before we begin, a couple of notes. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane, and the dial-in information will be displayed. If you're having technical issues, or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a survey link will be emailed to you. We would greatly appreciate it if you could fill in this survey. Again, if you have questions for our faculty, we will have a Q&A portion at the end of the webinar, so please submit those questions in the question pane on the right-hand side of your screen. Without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and greetings everyone from Berlin, Germany, where I am at EADV, and the local time is 3:30 a.m. here in Berlin. I am very happy to be here tonight, and we're gonna start with a couple of remarks on IDEF, International Dermatology Education Foundation. So International Dermatology Education Foundation is a non-profit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. We have done several webinars in the past, as well as live meetings through all over the world, and we have addressed our viewers in North America, South America, globally, as well as in Southeast Asia and Europe. Tonight, we are very lucky to have Dr. Matthew Zerwas. He is a good friend of mine. He is a genius of contact dermatitis, as well as all dermatologic diseases, but specifically atopic dermatitis. He is the Director of Clinical Trials and Dermatitis Center in Bexley Dermatology. So I'm very excited and happy to invite him here tonight, and he's gonna tell us all about atopic dermatitis and a patient journey. Welcome, Matt, and take it over.
Thank you, Leon, and I've been assured that for anybody who's worried, I've been assured that they are going to allow Dr. Kircik back into the country. There's always some question in my mind whenever he's gone, but let's just go ahead and get started. So again, I'm Matt Zerwas, I'm a dermatologist in Columbus, Ohio. I've been doing pretty much nothing but dermatitis for the last 20 years. And that really started as an interest in contact dermatitis and then developed into an interest, particularly in adult atopic dermatitis. Now run a clinical trial center and did the Opzelura trials. And I cannot tell you how excited I am tonight, because the data that you're going to see tonight, this deck just got approved yesterday. Going to be some of the first people in the world seeing it, and they've done a phenomenal job of really capturing what it is that makes Opzelura special, because this drug, and I'm going to back up. I always try and say things that maybe people go, and then I want to back it up and prove it to you as we go through the presentation. And I want to tell you that, in my opinion, this drug is the most revolutionary topical that in the history of my career, and there are some very specific reasons I say that, and I'll see if I can back it up and convince the rest of you as well. So Opzelura is indicated for the topical short-term non-continuous chronic treatment of mild to moderate atopic dermatitis In non-immunocompromised adult pediatric patients 12 years of age and older, disease is not likely controlled with topical prescription therapies or when those therapies are not advisable. So I'm presenting on behalf of and being compensated by Incyte. This information is going to be consistent with FDA regulations and guidance and the US FDA approved label, and only questions that are on label will be able to be answered. Port safety information will be covered and full prescribing information is available. Now, I just read the indication. I'm not going to make you listen to it again, but I am going to point out to you the idea of why we've got two indications listed here, right? So after the one that I already read, we've got Opzelura is indicated for the topical treatment of non-segmental vitiligo in adult pediatric patients 12 years of age and older. The big difference that jumps out at you between those two is that in the atopic dermatitis indication, it's topical short-term and non-continuous chronic treatment, so specified how it's okay to be used, whereas in vitiligo, it just says topical treatment of non-segmental vitiligo. And, as somebody who doesn't, if you're somebody who doesn't do trials or there's a lot of familiarity with how this all works, really where those indication statements come from is the way that the trials were designed. So in the atopic dermatitis trials, it was used twice daily for 8 weeks. And then after that, it was used as needed. And I'll explain exactly, how do you do as needed in a clinical trial. But so since that's how it was done in the trial, that's what the indication says. In vitiligo, it was just used twice daily long term. And so there's no discussion or limitations in the vitiligo portion about how long you can use it for. And so I point that out because it's not that there was some safety issue that, oh my gosh, if you use it for more than 8 weeks, good Lord, something happens. It really is just that's how the trials were done. It's an important safety information, right? So serious infections leading to hospitalization or death, including tuberculosis, bacterial, invasive fungal, viral, other opportunistic infections. And we're going to talk about all of these in some more detail later about where these warnings come from. And we're going to look at the data to tell us, how worried do we need to be about these things? What's the data actually tell us? I'm sure most of us have heard this by now, but where these warnings are coming from was the trial with Xeljanz or tofacitinib that did show increased risk of some of these things. Because of that data, these warnings were then put on all JAK inhibitors out of an abundance of caution from the FDA. Right. So the other things here, higher rate of all-cause mortality, including some cardiovascular death, lymphoma and other malignancies have been observed in patients treated with Janus kinase inhibitors. Higher rate of MACE has been observed in patients treated with Janus kinase inhibitors, MACE meaning major adverse cardiovascular events. And then thrombosis, DVTs, PEs, arterial thromboses have occurred in patients treated with Janus kinase inhibitors for inflammatory conditions. We'll talk about this more in detail later, but the thing that is really crucial here, notice that nowhere in any of those statements does it say that any of these things happen at an increased rate in patients using Opzelura. Now, that doesn't mean that they don't, right? But the FDA is very specific in their wording, and I just want you to notice nowhere in there does it say that Opzelura actually increases the risk of these things. The FDA just wants people to know that JAK inhibitors in general may increase the risk of these things, and they're basing that on the one trial done with Xeljanz in rheumatoid arthritis patients, and we'll look at that a little bit more as we go forward. Right, so atopic dermatitis. First thing here that I want you to really think about, right? So 13% of children, 7% of adults. What does that tell you? Right, well, what it tells you is that this is a disease of adults. Atopic dermatitis is not a disease of children. Anybody who thinks that hasn't thought this through, right? Atopic dermatitis is primarily a disease of adults. Now, I want you, hopefully you're sitting there thinking, what the heck is this guy talking about? It's twice as common in kids as it is in adults. Well, think about the numbers for a minute, right? 13%, so adults make up 80% of the population, kids make up 20%, right? So 7% of 20% is 1.4% of the population. On the other hand, 7% of 80%, excuse me. So 7% of adults make up 80% of the population. So 7% of 80% is 5.6%, right? That's what percent of the population are adults with atopic dermatitis. 13% of 20% on the other hand is 2.6%, right? So there are twice as many adults with atopic dermatitis as there are kids, right? So this is a disease of adults. Right, there are many more adults, twice as many adults with atopic dermatitis as kids. The other thing I want you to see about this number is that 7% of adults, well, that is 2 to 3 times the number of adults with psoriasis. Now, do you make the diagnosis of atopic dermatitis 2 to 3 times as often as you make the diagnosis of psoriasis, right? I still hear from people all the time, I just don't, it's great that we get all these new drugs, but I just don't see that much atopic dermatitis. Well, if you're saying that and you're thinking that, then that means you're really thinking about atopic dermatitis in an outdated way, because the where these numbers come from is not the way that I was taught to think about atopic dermatitis as a resident. What I was taught as a resident was that atopic dermatitis starts in childhood, is flexural, and is associated with atopic comorbidities. None of those things are necessary for the diagnosis, right? We have diagnostic criteria from the AAD. Those are the most recent diagnostic criteria that we have here in the US. They've been endorsed by the FDA. And what those diagnostic criteria say, right? What does the FDA say atopic dermatitis is clinically? The FDA, the AAD say it's chronic spongiatic dermatitis that spares the groin and axilla. Now, if it involves the groin and axilla, it still can be atopic dermatitis if it's flexural in any age. So it's chronic, it's itchy, it's spongiatic, it spares the groin and axilla, and you don't think it's anything else, right? So you don't have another pathophysiology. So it's not atopic dermatitis. It's not contact dermatitis. It's not scabies. It's not CTCL. It's not seborrheic dermatitis. It's not photosensitivity, right? So unless you have an alternative pathophysiology, unless you have a reason for them to have their spongiatic dermatitis, chronic spongiatic dermatitis is atopic dermatitis. So when people say to me, I just don't see that much atopic dermatitis, what I believe they really mean is, I just don't see that many people who had childhood onset atopic dermatitis that was persistent into adulthood. If you instead say, how many people have you seen with chronic spongiatic dermatitis where there wasn't an obvious etiology? Well, I see those people all the time. Then you're seeing atopic dermatitis all the time. And really thinking about the disease that way. And we'll talk more about what is the pathophysiology. We'll talk about that a little bit more as we go on. But that really is there's been this major broadening of what we think of as atopic dermatitis based on these diagnostic criteria, right? And so 21 million people ages 12 and above have atopic dermatitis. That's, again, way more than the number of people under 12 who have atopic dermatitis. And that number is going up over time, right? And here's one of the key things about atopic dermatitis. It is, I think, the only inflammatory dermatosis where if I give you a classic lesion, right? If I showed you a piece of skin this big that has classic atopic dermatitis and a biopsy of that is classic histologic features, you absolutely cannot make the diagnosis of atopic dermatitis. The appearance of the lesions and the histopathology, absolutely, it's not even can never make the diagnosis, because the actual appearance of the spongiatic dermatitis and the biopsy results absolutely cannot distinguish atopic dermatitis from allergic contact dermatitis, from scabies, right? All of them have an identical histologic picture, and the actual dermatitis looks the same. Now, if I started to give you more clues, like where is the dermatitis, how long have they had it, things like that, then that's how we start to can make some clinical assessments of if it's atopic dermatitis or allergic contact dermatitis or scabies. But every other inflammatory dermatosis, if I showed you a classic lesion of psoriasis that big, or lichen planus, or granuloma annulare, or pleva, or PLC, or LPP, seborrheic dermatitis, if I showed you a classic clinical lesion in a small patch of skin and gave you a classic histology, you can make the diagnosis with certainty. You cannot do that with atopic dermatitis, and that's why these diagnostic criteria become so important. All right, so classically, right, it's symmetrical, it's ill-defined, patches or plaques, lichenification, erosions, and I really like that in this deck they haven't set up predominantly affects flexural areas, because the data is in adults it specifically does not affect flexural areas predominantly. So, right, the latest data that came out comparing distribution in adults to distribution in kids, way less common in flexural areas compared to in kids. So the old things, the old ways we thought about atopic dermatitis, we would need to really rethink those so that we can help our patients, right? And then there's also the idea that on skin of color, it's harder to diagnose, the erythema is harder to appreciate, sometimes you can't see it at all, and even when you can, oftentimes it's violaceous and not a true erythema. Right, this is just to show us that itching is the primary thing for these patients. If there's one thing that they want, it's relief from the itch, and I cannot wait to show you the new itch data on Opzelura. It is the most impressive data that I have ever seen. All right, now I'm not saying it's the most impressive data that there is or anything like that, but it really speaks to what this drug does. It's totally consistent with my clinical experience, what it does for itch. All right. Where's this drug positioned in our therapeutic armamentarium? The label says they have to fail other topical therapies first. And so that could be a TCS, a TCI, a PDE4 inhibitor. Insurance may require that we try more than one of these before they'll cover Opzelura, but really Opzelura is indicated after people have failed at least one of these. Now, what does failed or not adequately controlled actually mean? So, right, the person who comes in and says, so say they're using a topical steroid, and it says use it for 2 weeks, take a week off. And they say, oh, I get a lot better in those 2 weeks, but boy, when I take that week off, it really comes back and I'm itchy. Then I start using it for the 2 weeks again, and it worked pretty well, but then on that week off, I'm going to get itchy again. That is not adequately controlled. Right? Adequately controlled means that the atopic dermatitis is no longer affecting their quality of life. And somebody like that who's getting intermittent relief with the topical steroids, that is not adequately controlled. Right? Now, what does the typical adult atopic dermatitis patient really want? They want something that when their atopic dermatitis shows up, when it starts to itch, they put the cream on, it stops itching, it goes away. They don't have to keep putting it on. So they want something they can use intermittently, reactively, whenever they get a disease flare, something that's going to get their atopic dermatitis better. And then they're just going to use it on and on as the atopic dermatitis comes and goes. And they want something they can be confident is going to work quickly and something that they feel safe using. And we're going to talk a little bit more about that as we go forward about how Opzelura really changes the paradigm of treating atopic dermatitis, especially in adults. Okay, so again, the treatment considerations, right? Diagnosis and assessment, sensitive skin areas, right? Using topical steroids in areas like the flexural areas, groin, face, places like that. But complexity of the treatment regimen. This comes back to what is so special about Opzelura, because traditionally, right, your atopic dermatitis patient might have 2 or 3 topical steroids of different potencies used in different places on their body, or they might have a topical non-steroidal. And really, those patients were never confident, because what their thought was, well, I know the topical steroid is going to work pretty quickly, but I don't want to use the topical steroid, right? And why don't they want to use it? Because think about if you went to your doctor with, we'll say, a headache, and they said, here, I want you to take this pill, take it for 2 weeks, then stop. Don't take it for more than 2 weeks. Got to take at least a week off. Then after you take the week off, you can use it for 2 more weeks and keep using it on and off like that, and that's safe, right? Any normal person would be like, well, God, if I can't use it for more than 2 weeks, it's probably better for my body if I only use it for 13 days. Well, you know what? I don't use it for 13, probably 12 is even better. You know, 10 is the most time. You know what? I don't want to put that stuff on at all, right? That's what patients hear whenever we say you can't just use this. You got to be careful. Don't use it in the wrong places. Don't use it too long. No matter how much we try and say this is safe as long as you do it the right way, but don't. Right? Patients don't feel confident using topical steroids, and most of the time they have more than one topical steroid, and they're not confident about which one to use where, how long they can use it for, any of that. So even though they know the steroid can work, they're not confident using it, and they're not comfortable using it. Now then we got the non-steroidal topicals that we've traditionally had, and they don't work as fast as topical steroids. We can all agree on that, right? Now the patients were confident, you know, they felt comfortable using them. They weren't worried that they're gonna, you know, oh, don't use it for more than this, don't use it for more than that. They're comfortable putting it on, but they know that it's not gonna work in a day, right? They're not gonna, oh, I started to break out, I'm gonna start putting my non-steroidal on, and tomorrow my itch will be better, right? That is not what patients were confident was gonna happen. So they were stuck with the idea they had the non-steroidals, they were comfortable putting on wherever they needed to, but they knew it wasn't gonna work overnight. The steroids, which they knew would work pretty quickly, but they weren't confident using. We bring in Opzelura. Now it's a single tube that you can use anywhere on the body, hands, palms of the hands, soles of the feet to the eyelids. You use it anywhere, and really what I call it is in anywhere, anytime. Put this on anywhere you got eczema, anytime you got eczema. When the eczema goes away, stop putting it on. Comes back, start putting it on again. That's it, right? That's how we instruct people to use it, and that makes them confident. They know what to do when their eczema starts to flare up, and they're confident that it's going to work. And they're confident that, if it starts itching Tuesday at work, that Tuesday they're going to go home and put the drug on, and by Tuesday night, there's a good chance that their itching is going to be better. And I'm going to show you that data, right? We have that data now that the drug works Well, I can't wait to show you, right? I'm setting the stage, but about the speed with which it works, right? So it really does make a huge difference for these patients to have a drug like this. Now, let's get into the pathophysiology of atopic dermatitis, and I actually really love this slide. So all atopic dermatitis, childhood, adulthood, is barrier function disease. It's things from the environment. And the way that my personal definition of atopic dermatitis is a Th2 epidermal reaction to non-specific environmental stimuli. And we know the types of non-specific environmental stimuli: patients own sweat, air pollution, pollen in the air, surfactants, so residual laundry detergent in clothing, hard water, all things like that. Non-specific environmental triggers causing a Th2 reaction in the epidermis. But now that, right, that's my definition of atopic dermatitis. And what that takes into account is that if there's a specific environmental trigger, it's if it's a contact allergen, that's contact dermatitis. If it's scabies poop, it's scabies, right? If it's malignant lymphocytes, it's CTCL. If it's malassezia, it's seborrheic dermatitis. But when there's no specific environmental trigger, and we see spongiosis, it's atopic dermatitis. That requires barrier dysfunction. And here's where the big difference, in my belief, is between adult and childhood disease. In childhood atopic dermatitis, it's a inherited genetic barrier dysfunction. It might be filaggrin, might be other proteins, might be steps in the ceramide processing spectrum, but it is an inherited genetic disease. In adults, here's what's fascinating. The latest data says it's not a genetic disease. It's not inherited. Instead, it's an epigenetic disease. So the chronic exposure to these environmental triggers causes epigenetic changes in the DNA of your keratinocytes. And so an epigenetic change means the sequence of your DNA stays the same, but they put on the epigenetic changes causes methyl groups to be added, and that upregulates or downregulates different genes. And those are permanent effects. So once a keratinocyte gets an epigenetic change that impacts its barrier function, that is permanent. So even if you take away the environmental trigger, that particular environmental trigger, we still have barrier deficit. And that is the underlying pathophysiology of atopic dermatitis. It doesn't, in kids, it's a genetic inherited barrier deficiency. In adults, it's acquired barrier deficiency, right? But so we get these allergens, environmental stimuli that penetrate through due to the skin barrier dysfunction. That triggers keratinocytes to release TSLP and other alarmins. Those trigger dendritic cell activation. Then the dendritic cells then pull the Th2 lymphocytes in. Now we start to get the Th2 response, IL-4, IL-13, more TSLP. And the IL-4 and IL-13 have direct effects on the keratinocytes. They downregulate barrier function, they downregulate antimicrobial peptide production, and they can cause hyperproliferation as well. So now we've got even a further worsening of barrier dysfunction. And then we get IL-13, IL-31 having direct effects on itch neurons. And so that again goes back to the speed of the itch relief, because the itch relief happens faster than the anti-inflammatory effect. Well, how is that possible? My belief is that it's because we're having a direct neurologic anti-itch effect. Because when we block IL-13 and IL-31's effect on the itch neurons become desensitized. So the itch neurons in atopic dermatitis, the IL-4 and the IL-31, the IL-13 and the IL-31 are causing them to get itch sensitization, which means they get activated too easily. When they get activated, they get too activated. So then these people itch, they scratch. The scratch makes the barrier even worse, and we get into the whole cycle. But it all comes back to the barrier deficiency and then the hyper Th2 reaction. But again, there's this neurologic anti-itch effect when we block the effect of IL-13 and IL-31 on these itch neurons. All right, so going forward, we know multiple cytokines are involved in atopic dermatitis: IL-4, IL-13, IL-31, TSLP, and they're doing different things. IL-4 is driving you in keeping that Th2 overexpression going. IL-13 and IL-31 are driving itch directly. IL-4, IL-13, and IL-31 are all driving inflammation, right? TSLP is activating the lymphocytes to begin with. And that's one of the things that's great about a drug like Opzelura, is that it impacts all of those pathways, right? IL-4, IL-13, IL-31, TSLP, and it's believed that those things all contribute to why it works so well for itch. So now let's get on to their clinical trial program. So the phase 1 trial, right, dose ranging, usual kind of thing like that. The phase 2 trial, this is going to be one of the first presentations where you really get to see. In this trial, they compared multiple different doses and frequencies of ruxolitinib application. One of the arms was using triamcinolone. Now, it wasn't powered to allow for statistical comparisons, but we can look at the raw numbers and just see, what were the results whenever people used triamcinolone, what were the results whenever they used Opzelura. So we can look at that. We can't make statistical assessments because it wasn't powered for that, but we can look at those numbers. And then we've got the TRuE-AD1 and TRuE-AD2, which were the pivotal trials. So Opzelura's trials, right? So in their main pivotal trials, patients 12 and above, AD for at least 2 years, an IGA score of 2 or 3, and a BSA of 3% to 20%. They did ruxolitinib 0.75, Opzelura, which is ruxolitinib 1.5% versus vehicle, did it twice daily for 8 weeks. Then at the end of 8 weeks, they went into a long-term extension where everybody got Opzelura. And what happened when your lesions cleared, you stopped putting Opzelura on. When the lesions came back, you started putting it on again. When they cleared, you stopped again. So, right, this is real world use. This is as needed use, right? So, and it is fascinating, right? I think of Opzelura as the fastest drug that we have in dermatology, but then one of the drugs for atopic dermatitis that has really good long-term efficacy with as needed use. And I'm going to show you that data, right? How well do people do with just as needed use long-term, right? Because that's what our patients are doing. And then the primary endpoint was IGA treatment success, meaning an IGA score of 0 or 1 plus a 2-grade improvement. So if you came in as a patient who was mild, to be treatment success, you had to get to 0, completely clear. And then secondary endpoints were primarily around the itch and easy score. All right, so the baseline characteristics of this population. 40% of people had facial involvement at baseline. It's one of the things that we tell you that you wouldn't think, based on the way we were all trained about atopic dermatitis. Facial dermatitis is that common atopic dermatitis. Oh, yes, it is. Right, 40% of the people in this trial had facial involvement, and that's why we're comfortable saying, yeah, you can use it on your face. Okay. The other things that I really want to point out in particular is that the mean NRS itch score was 5, because the secondary endpoint was a 4-point reduction. Well, if the mean number coming in was 5, then right, to get a 4-point reduction, you gotta get down to an itch of 1. Itch of 0 or 1 is considered an itch-free state, right? So it was a really high bar to get to itch success because these people came in with an itch score of 5 on the 0 to 10 scale. Now, if you're not familiar with the itch NRS scale, an itch score of 0 or 1 is considered an itch-free normal person state. 2 or 3 is considered itch that is bothersome, but not really impactful. So for those of us who don't have eczema, maybe the equivalent of a mosquito bite. All right, itch of 4, 5, or 6 starts to impact your activities of daily life. So you're going to be distracted at work. You're going to be less productive. You might be a worse driver. You might sleep worse. And then itch 7, 8, 9, and 10 is severe. And so severe itch is dramatically impacting your quality of life and your ability to function. All right, but so 0, 1, itch free, 2 or 3, itchy but not killing you. It's 4, 5, and 6. Now it's starting to impact you because it's so distracting. And then 7, 8, 9, and 10, you almost can't think about anything else. All right, so going forward, how many people got treatment success at 8 weeks? Over half. Right, so over half of people got to clear or almost clear. Now it's an interesting question as well. What the heck does almost clear mean? Well, almost clear is technically defined as barely perceptible. The way that I think about it is that it's barely perceptible to us as professionals. So for a patient who's at almost clear, they're going to look at where they had eczema and say, oh, my eczema's gone. Well, we're going to look at them and say, oh, it's just a tiny bit pink right there. I see one scale, might be a tiny bump, right? So it's almost clear from our perspective, but from their perspective, they can't tell they have eczema anymore. And so over half of people who use this drug at 8 weeks can't tell they have eczema anymore, right? We're almost to 50% by week 4. We're at 25% by week 2, right? So fast acting in terms of getting the rash better. And right, so here's somebody at baseline. Here they are at week 2. We can see this is already, very much better. And then by week 8, there's still an IGA of 1. No, I would say in this area, particular area we're looking at, they're an IGA of 0 at that point. But here's a great example of hand dermatitis. I get asked all the time, does Opzelura work for hand eczema? Does it work for dyshidrosis? Well, my answer is that I don't know if it works for dyshidrosis, but I haven't used the diagnosis of dyshidrosis in years. Right? When I see dermatitis on the palms, that, unless it's contact dermatitis, that is atopic dermatitis limited to the palms, manifesting primarily as small deep-seated vesicles, right? What did I just describe? What was historically called dyshidrotic eczema, but dyshidrotic absolutely meets the diagnostic criteria for atopic dermatitis unless there's a contact allergen. All right, so does it work for dyshidrosis? Well, if there's non-atopic dyshidrosis, if there's dyshidrosis that is not atopic dermatitis, I don't know if it works for that. But for every patient that I've seen with what I would have traditionally called dyshidrosis, now that I understand the diagnostic criteria, to me it's atopic dermatitis of the palms. And yes, Opzelura works just as well there as it does anywhere else. All right, so this was a 67-year-old guy with about 3% BSA, both palmar and dorsal aspect of the hands. Another example, here's a patient with skin of color. And right, we can see the raised aspect of these lesions is better. The pigmentation has started to return to normal. That's one of the nice parts about Opzelura is that we don't have to worry about drug-induced hypopigmentation like we do with topical steroids, right? And then the itch relief, right? So over 50% of people get a 4-point reduction in itch. And remember, the baseline itch score was 5. So to get a 4-point reduction, you basically had to get to an itch-free state. All right. So that, and I'm going to show you more data around that as we go forward a little bit here. Right. Here's another example, IGA of 3 going down to an IGA of 0. Right. This is an 88-year-old man. But here's right in the first week, this is study day. By week 7, these people with atopic dermatitis have gotten to an itch-free state, an NRS of 0 or 1. That is still not the most impressive data I'm going to show you. Right. I get so excited about this as we move forward to it. Right. So this is to me, the slide that is just stunning. So in this was an open label trial that people put the Opzelura on, then they asked them about their itch at 15 minutes, 30 minutes, 1 hour, 2 hours, 4 hours, 6 hours, and 12 hours. In 15 minutes, they got most of their itch relief in the first 15 minutes, right? Imagine it for a minute. Like, it's hard when you really stop to think about that. Imagine if we had a drug like that for acne, where, Joey's in for, he came from school, his mom's gonna take him back to school at the end and say, hey, Joey, here's the sample, put this on your acne, you'll be noticeably better by the time you get back to school today. And imagine if we had a drug like that, or a drug like that for psoriasis, because itch is the most bothersome symptom of atopic dermatitis. Imagine if we had a drug that worked on the most bothersome symptom of psoriasis in the first 15 minutes. We would say to a patient, hey, put this on, and in 15 minutes, you're gonna see a noticeable difference in the redness, the raisedness, and the scaling, right? Because it's the appearance of psoriasis. But the main, most important, most bothersome thing in atopic dermatitis, 15 minutes, right? It really sinks in whenever you think about it in the context of other diseases. 15 minutes. Again, imagine if you had a drug, a topical, that made a meaningful difference in acne or psoriasis in 15 minutes. Right? That's what I mean whenever I say this, to me, is the biggest advance in topical therapy in my career, because a drug that does that, maintains that response, and gets the atopic dermatitis better, right? And it's not a vehicle effect, right? Because if it was just putting on moisturizer, we would see it get better and then get worse again and then slowly get better. This is drug effect, right? And this is what I really believe has to be a neurologic effect. How many people got to EASI 75, over 60% by 8 weeks? How many people got to EASI 90? About 45% over 8 weeks. EASI score, though, is a terrible measure of low body surface area atopic dermatitis. So, you kind of have to report EASI score if you're doing an atopic dermatitis study. But for low BSA, EASI score is a terrible measure of disease, right? Now, why do I say that? Because in an EASI score, if you've got 10%, if you've got 9.9% body surface area involved, your body surface area factor is 1. If I get you 99% better to where you only have 0.1% body surface area left, but it's still just as red, just as flaky, just as raised, but it's only 0.1% body surface area, and it used to be 9.9%. According to EASI score, you got no better at all, not one bit better. Now, on the other hand, if I took you from 10.5% body surface area down to 9.5% body surface area, so only got you 10% better, that's actually, according to EASI score, you got 50% better, because your body surface area multiplier went from a 2 to a 1. So this is why EASI score is a really bad measurement of low body surface area atopic dermatitis, but it's still something that has to be reported. We look here at the treatment emergent adverse events: nasopharyngitis, bronchitis, ear infection, eosinophil count, urticaria, diarrhea, folliculitis, tonsillitis, rhinorrhea, right? All of these except for nasopharyngitis, 3 or 4 patients. Then we had 1 or 2 patients each who got neutropenia, allergic conjunctivitis, pyrexia, seasonal allergies, herpes zoster, otitis externa, staph infection, acneiform dermatitis, right? 1 or 2 patients each, because if 3 people got it, you made it up here. 1 or 2 people out of 500 got each of those things. But then look at the application site reactions: 0.8% experienced any burning, 4.4% with vehicle, right? So any cream is going to cause burning in a small percentage of people. The rates of burning are similar to what you would see with a steroid cream, right? Pruritus, application site pruritus, 0% with Opzelura, right? And discontinuation rates very low, right? 0.8% with Opzelura versus 3.2% with vehicle. So that's reassuring. And then here, whenever we look at the extension, right, where people were using as needed. So this is PRN use, maintains 75 to 80% of people at clear or almost clear, meaning that as far as the patient is concerned, they can't even tell they have eczema. 75 to 80% of people with just as needed use, PRN. This completely changes the paradigm of atopic dermatitis. Where use moisturizer every day, use topical steroid twice a day whenever you're better, and delay the onset of flares, and use TCIs when you're not using topical steroids. No, here's a cream, put it on when you get eczema, and the eczema's better, stop putting it on. Eczema comes back, start putting it on again, right? This is simple, intuitive, and it really changes the way that adults feel about their atopic dermatitis. Okay, now mean BSA, again, same thing, dropped down to 1 to 2% and stayed there with just as needed use. Exactly what we'd like to see. And then whenever we extend the data out further through 52 weeks, no new safety data really came out where we said, oh my gosh, we use it for too long, and we started to see stuff happen, just didn't see that. Now, the other thing that we want to talk about is this was their phase 2 trial. That vehicle, here they did TAC BID for 4 weeks, then they switched on to vehicle BID for 4 weeks. We also were doing lower concentrations of ruxolitinib. We were doing ruxolitinib once daily and ruxolitinib Opzelura twice daily, right? In the primary endpoints were the change in EASI score at week 4 for Opzelura versus vehicle, but there were a number of secondary endpoints. All right, so how did it compare to triamcinolone cream? So how many people got itch on RS4? 60 at 4 weeks, right? So 4 continuous weeks of triamcinolone versus 4 continuous weeks of Opzelura. 62.5% of people got a 4-point reduction in itch compared to 32.3 with triamcinolone. Treatment success IGA, so going down to an IGA score of 0 or 1 with a 2-grade improvement. 38% in 4 weeks with Opzelura, 25% in 4 weeks with triamcinolone. EASI 75, 56% versus 47, but EASI 90, 26% versus 13%. Again, we can't make statistical, we can't have p-values here because this wasn't adequately powered to look for them, but you can make your own assessments based on these raw numbers, right? It's not, when I look at these, it's not like, well, this one's here and that one's right there. No, these are big differences. These are big differences. So and then what I mentioned earlier, why are there these box warnings? Well, it was the Xeljanz oral surveillance study. And remember again, what this study showed, it did not show that there was an increase in MACE or VTE with tofacitinib. What it showed was that people on tofacitinib had a higher rate of those things than people on a TNF, on adalimumab. Well, we know that TNFs bring down the rates of MACE and VTE. So it may just be that the tofacitinib just didn't decrease it as much as the TNF did. Now, we don't know that that's what it means. It might be that tofacitinib actually increased it and the TNF just didn't affect it. We don't know. But remember that this wasn't like Xeljanz versus nothing. This was Xeljanz plus methotrexate versus Humira plus methotrexate. Most of the patients were on prednisone as well. But based on the results of that study, they put the box warning on all JAK inhibitors used for inflammatory conditions. Now, I really want you to notice here how the FDA is very precise in their wording. So when there is data showing an increased risk with a drug, they are very clear about it, very clear, right? So we have to read FDA box warnings very carefully, right? So patients treated with oral Janus kinase inhibitors for inflammatory conditions are at risk for developing serious infections that may lead to hospitalization or death. Reported infections include tuberculosis, invasive fungal infections, bacterial and viral infections, right? Notice here, nowhere does it say that people treated with Opzelura are at increased risk. If there was data that showed that, it would very specifically say that. Now, I'm not saying that there isn't an increased risk, right? Because the label certainly doesn't say that. But notice very specifically what the FDA is saying here, right? So avoid Opzelura in people with an active serious infection. Treat it before you put them on the Opzelura if they get an infection while they're Opzelura, and interrupt the Opzelura until the infection is treated. Right, serious lower respiratory infections were reported in clinical development. It was being developed in part during the time of COVID. No cases of active tuberculosis were reported in the clinical trials with Opzelura. Viral reactivation has been reported in people using Janus kinase inhibitors. In particular, there were some cases of zoster. We'll look at exactly what those numbers are. And hepatitis B or C have been noted to get worse in people taking oral ruxolitinib. So there's at least some imaginable concern that topical ruxolitinib could affect the ability to keep hepatitis virus infections under control. Now let's look at the actual data. Serious infections, one case, right, in the 466 patient years with Opzelura. Opportunistic infections, none. Tuberculosis, none. Herpes zoster, there were 5 cases of herpes zoster. And really, it's hard to put these kind of numbers in context unless you know the background rate in the general population. So if that's something that you think would help you to put it into context, ask your Opzelura rep. They can get you in touch with the MSL, who actually can provide you some information about what are the background population rates that are expected for things like zoster or MACE or VTE. Right? Mortalities, nobody died. Lymphomas, no lymphomas. 2 non-melanoma skin cancers in 500 years of patient exposure. Right? Other 466 years. Right? Other malignancies, none in 466 years of patient exposure. Cardiovascular death, none. Myocardial infarction, none. Cerebrovascular accident, there was 1 stroke. Right? Pulmonary embolism, there was 1. DVT, there was 1. And again, it's hard to put those numbers in context, right? If those are events that happen to 1 out of 500 people, well, if they normally happen in 1 out of 10 million people, that 1 in 500 is a big deal, right? If they normally happen in 1 out of 200 people, then the 1 in 500 might be actual maybe it's protective. You got to know what the background expected rates are in the population. And like I said, if you think that's something that would be helpful for you to put this into context, ask your rep. They can get you in touch with the MSL who can provide that information. Mortality, again, larger randomized post-marketing study, rheumatoid arthritis patients with at least 1 cardiovascular risk factor, comparing an oral JAK inhibitor to a TNF, high rate of all-cause mortality, right? Very clear, a higher rate of all-cause mortality, right? But this is with an oral JAK that's a different drug, right? It does not say that Opzelura increases your rate of mortality, we looked at that data, right? Malignancies were reported in patients treated with Opzelura, right? The malignancies that we just looked at, right, they were skin cancers. Lymphoma and other malignancies when observed in patients treating JAK inhibitors to treat inflammatory conditions, and RA patients, blah, blah, blah. Again, very clear. In RA patients treated with an oral JAK inhibitor, a higher rate of malignancies was observed. It does not say that there's a higher rate of malignancies in patients treated with Opzelura. Again, I'm not saying that there isn't. It certainly doesn't say that Opzelura does not do this, but it doesn't say that it does, right? So that what the FDA wants people to know is that this drug is a JAK inhibitor, and there are JAK inhibitors that have been shown to increase the rates of these things. And so it is at least possible. And the FDA wants people to know that this has been reported with JAK inhibitors and that this drug is a JAK inhibitor. So their FDA is using an abundance of caution, which is reasonable, right? Now, and I'll talk to you in a minute about how I talk to patients about these things. Major adverse cardiovascular events, again, the same kind of thing, right? Doesn't say that Opzelura increases the risk, right? It does say discontinue Opzelura in patients who had a myocardial infarction or stroke, and then thromboembolic events were observed in trials with Opzelura. Notice again, it doesn't say at an increased rate. Thrombosis, PEs, DVTs, arterial thrombosis, JAK inhibitors for inflammatory conditions, many of them are serious and resulted in death. Again, it goes back to talking about the tofacitinib trial. All right, so how do I talk to patients about this? Because I think it really is useful, because what you want to do is give them the context of that information. And I've tried a lot of different ways of doing this, and here's what I have found works. Right, so if I start by saying, oh, by the way, you're going to get warnings from the pharmacy about things like heart attack, strokes, death, cancer, brain shut, but don't, it's because the brain is already turned off too late. You haven't got a chance to give them the context. So here's the way that I talk about this to patients. So, we've got this new cream. You're going to put it on twice a day, anywhere you got eczema, anytime you got eczema. When the eczema goes away, stop putting it on. Starts coming back, start putting it on again. It's going to work really fast, and a lot of people works within the first 15 minutes. But I do want you to know you're going to get some warnings from the pharmacy about some scary sounding things. Now, the reason you're getting these warnings is because a drug that is kind of similar to this one, when taken as a pill, did show an increased risk of these things, and the FDA wants you to know that. Now, the first thing that I would tell you here, don't eat the cream, all right? Because we know you can take this stuff by mouth, and maybe this stuff, right? But don't eat the cream, all right? But the FDA really just want you to know about this other medication that was taken as a pill, and so they want you to know about that. But again, these scary things were not seen at increased rates in the studies with people using this cream. But the FDA really wants you to know that it's at least imaginable that there could be an increased rate. Now, what are those scary things? Oh, they're scary things, you know, death, heart attacks, strokes, blood clots, cancer, serious infections. But again, those were shown with a different medication taken as a pill. So I just really want to emphasize, don't eat the cream, right? That's the discussion I have with patients. That is very accurate and very much in what the FDA wants people to know, right? Because the FDA, it's not like they want us to say, oh my gosh, this cream increases the risk, because there's no data that shows that it does. But they want patients to know that similar medications taken as a pill did, right? And so it's at least possible. That's what the FDA is really getting at here, right? So what are the dosage administration? Thin layer twice daily, up to 20% body surface area. You know, one of the questions I always wonder about, well, what if you only use it once a day? Again, there is some data on that from the phase 2 trial. If that's something you're interested in, talk to your rep, and they can get you in touch with the MSL. Topical use only, right? Don't eat it. Don't put it in your eye. Don't use it intravaginally. Directly apply it to the lesion. Stop using whenever it gets better. If you don't get better in 8 weeks, this probably isn't the drug for you. And then it's non-greasy, steroid-free cream, right? It's a very nice vehicle. And then going on with safety information, a few things just to point out in case you ever notice them, right? Perform CBC monitoring is clinically indicated. That does not say you perform CBCs. It says if you want to for some other reason, that's fine. But the FDA is not recommending that you perform CBCs. Lipid elevations been seen with oral ruxolitinib have not been seen with topical ruxolitinib. To me, that is, again, reassuring that we're not getting enough systemic absorption to have a systemic effect like a lipid elevation. We already talked about these adverse reactions. Pregnancy and lactation, right? You obviously would not want to use this drug in people who are pregnant or lactating because some of it is going to get absorbed and therefore some of it is going to get into the baby, right? First and only topical JAK inhibitor. Targets multiple of the cytokines used in atopic dermatitis, IL-4, IL-13, IL-31, TSLP. Clear, almost clear skin in most patients by week 8. It's on RS4 in most patients by week 8. 30% of patients get it at week 2. It's on RS4 seen as early as day 2. I showed you the data though, 15 minutes. People are noticing a very meaningful reduction in their itch. Adverse reactions we talked about, and again, it's non-steroid, there are no injections. It's fine to use it in sensitive areas. And so now let's just look at a few of the patients that are going to be really the home runs for Opzelura. So right, Isabel's a 38-year-old. She's a chef. She's messing up her recipes because she's distracted by her itch. She's having sleep issues at night, so she's irritable in the kitchen. Right, she's worried about the oh my God, is my itch, is my eczema gonna get flakes falling into the food? She's tried multiple topical steroids, but she still is just really itchy, right? This is somebody who now we've got a drug. Hey, when you start to itch, put this on in 15 minutes, you're gonna see a difference in your itch, right? We now have somebody, even if it's working relatively well for the appearance of the lesions, if she's still itchy, it is still affecting her. Right, another example, right? Here's Sarah Beth. She's a 59-year-old. She's got eczema on her face and her upper chest, right? She maybe had some good success with steroids, but she's doubtful about using steroids on her face and near her eye, which is understandable, right? The tacrolimus she's using is greasy and it burns when she puts it on, so she's not satisfied with that. Again, this is a home run Opzelura patient, right? So it really makes a huge difference for a patient like this, who now they've got a drug that they can use, same medication they can use on their chest, where traditionally we might use a medium to high potency topical steroid, and on their face, where traditionally we might use a low potency topical steroid or a non-steroidal. Now they got one cream they can use everywhere, and they're going to be very confident that it's going to work. We've got Faith, right? So Faith, the topicals have not gotten her eczema better. We can still see the obvious manifestations of her atopic dermatitis, especially her hands and her forearms are bad because she's constantly washing them in her job as a nurse. She's been using topical steroids long term, but really hasn't gotten better. She's worried about atrophy, stria, dyspigmentation. Again, this is somebody who the topicals haven't worked well enough, the topical steroids. This is somebody who's, again, a great candidate for Opzelura. Here we got Henry, a 32-year-old guy. He's got 18% body surface area. Now, normally I would say you can't treat 80% topically, right? There's not enough medicine in the tube to begin with. And number two, people are going to put it on 80% of the body consistently. But when you've got a drug that works this fast, If it can get his 18% down to 5% in 3 or 4 days or a week, and then he's only trying to treat 4 or 5% topically, it's doable, right? So it is not unreasonable to try Upsilon even in patients who are in that 10 to 20% range. Because if they've got, pretty bad atopic dermatitis over 50% of their body, no, it's not going to get it better in 3 or 4 days. But if they've got fairly mild atopic dermatitis, even if it's widespread, the Upsilon can get them better so fast that it gets down to a manageable amount of application for topical use. All right, so this guy's used TCIs, probably used TCSs, really doesn't want to do shots. This is a very reasonable option to try in him if it can get it down to a better body surface area quickly. We've got Alex, a 13-year-old. Adolescents, I feel so bad for. I have a 15-year-old daughter. I got to talk a little bit low at home. If she knows what I'm talking about, or I'll get in trouble. Right, the other day, I was talking to her, says, "Oh, I'm giving a lecture about eczema." She's like, "Oh, eczema. Oh, there was this girl at camp this summer who had eczema, and she rubbed some of her eczema juice on me. Oh, I wouldn't talk to her the rest of the summer." I was like, eczema juice? What the hell is eczema juice? Like, what the heck is eczema juice? She was like, "Oh, it was like here at her forearms, and it was like this liquid was coming out of it. It was so gross." Right? That's what teenagers deal with, right? If there's somebody in the world who should be tolerant of eczema, it should be my kids. Right? That's what I get for my daughter. Right? So for adolescents, I think we have a higher bar of trying to really get these kids relief from the appearance because of the social stigma associated with atopic dermatitis or anything wrong with their skin as an adolescent, right? And this kid, it's one of the interesting things, loves baseball, but itching during games has frustrated him. If you ever hear somebody say, "I'm allergic to my own sweat," or "my sweat makes me itch," that is almost pathognomonic for atopic dermatitis. People who give that history, if you collect their sweat and prick test them with it, 85% of them will have a positive prick test to their own sweat. So they're allergic to it. Now, are they allergic to the actual sweat? No. What they're allergic to are microbial antigens that the sweat, whatever it happens, solubilizes and makes available to cause the symptoms. Somebody who says, "As soon as I sweat, I start to get itchy," that is almost pathognomonic for atopic dermatitis. That's one of the things happening to this kid, right? He's seen the school counselor because he's, concerns about the appearance of his lesions. His mother sees the impact that his AD is having, but she's really concerned, even though she knows how much it's affecting him, she's really worried about the long-term effects of topical steroids. And right, we could try and talk her out of that, but how much success do we really have talking moms out of being worried about topical corticosteroids? We don't. Right. So now we've got a new non-steroidal option that can really make a huge difference for this kid. Right. And patient selection and access, right? They're going to be 12 years of older. They got a less than 20% body surface area. They have to fail at least one topical. Often they have to fail more than one topical for insurance coverage. We got prior authorization and appeals assistance to cover by meds. We got a copay savings program with their savings card. We got a patient assistance program for patients who are uninsured or underinsured and are not able to afford their medication. And so that is it. Now I took up everything except for the last 5 minutes, but if there's anything, if I've been droning on, but if there's anything that I didn't cover during my droning on, I would love to answer any questions that anybody has about Opzelura or atopic dermatitis. As we discussed earlier, we do have to stay on label, but if anybody has any more questions, I would love to answer them.
So Matt, thank you so much for that enlightening lecture, but we do have a burning question. What are the ingredients of the eczema juice? No, I'm just kidding.
Leon, if it would, I could try and collect some. We'll see if it grows hair. That might.
That was really good. That was really good. But seriously, actually, I do have a question because you brought up a very important scientific point that's sort of under discussed or even not very well discussed, and you touched upon it, but it would be great if you can elaborate. Tell me the difference between the epigenetic disease in adults versus you mentioned genetic defects in children.
Yes, so it's been fascinating in the last couple of years. So they did this study in the UK where they looked at people who got diagnosed with atopic dermatitis as an adult and what they were expecting. And they looked at their genetic profile, and what they were expecting to see was that they had the same mutations as kids, but maybe they had compensatory mutations or different mutations. They didn't have the same mutations as kids. They didn't have any mutations. There was a very low genetic risk score for them, but they found that air quality was a meaningful predictor of who was going to get adult atopic dermatitis. And then a guy named Ian Miles at the NIH has showed similarly that air pollution, and particularly isocyanates, predict who's going to get atopic dermatitis. Well, then the other line of research that then has been kind of answering that is there are groups looking at these epigenetic changes. And you know, what I now think, and this is a little bit hypothetical, right? We know that air pollution is a big cause. We know that surfactants are a big cause. And the main source of surfactants is probably residual laundry detergent and clothing, more than what you bathe in. We know that hard water is a big cause. Well, if you think about it, if you mainly are getting from air pollution, you're more going to get these epigenetic changes on your face and your arms. If you're getting it more from clothing, you're going to get it on the backs of your thighs, your back. If you're getting it more from hard water, it might be scattered over your whole body. But these epigenetic changes from these chronic low-grade environmental exposures, and it's really useful clinically because patients love this answer. Because, right, what do you always get from them? Why did I get this? I didn't change anything. I didn't change my products. I didn't change my job. I didn't move. I didn't change my diet. My kids did nothing. I haven't changed anything. Why did I get this? And their answer used to be, you got old, right? Your skin wore out. Patients don't like that answer. Instead, now the answer that we've got is when you were born, your skin looked like this, and nothing could get into it. But the chemicals you've been exposed to over your whole life, over the last 40 years, the air pollution, the laundry detergent, the soap, the hard water, been slowly damaging your skin and causing these gaps to open up. And a year or two ago when this started, those gaps finally got big enough that now stuff can get in, and that is what's triggering your eczema. Patients love that answer. It really, makes them comfortable. Okay, because it was something in my environment, but you can't. Getting away from that stuff isn't going to heal the gaps back up. Once the gaps are there, those epigenetic changes are going to keep them open, and so that's where we have to treat people. We have to get them away from trying to find the environmental changes they can make because the damage is already done, right? It'd be like taking a patient with AKs and skin cancer, saying we don't need to treat your AKs or your skin cancer. You just need to get out of the sun now. No, it was the damage. It was the sun that was damaged. It was done 30, 40 years ago, not the damage that's being done right now. And that's how we think about this epigenetic changes in adults. It's been a really interesting sort of vein in the research of now that we're starting to understand same disease, barrier dysfunction in both kids and adults. But just do you get there because you got a genetic mutation, or do you get there from the environmental exposures? It's just a really interesting phenomenon.
That really is, and I think that's really interesting news, and hopefully we'll learn more about it. One more question from the audience. What's the age indication for Opzelura all the way down to, I believe it's 12, correct?
Down to 12, they are doing studies down to a younger age. I don't have any, I don't know if it's going to get approved or not approved. I haven't seen the data yet or anything like that, but they are working on even younger indications, but those are, we don't know if they're going to get younger indications or not. Right now, it's down to age 12.
And I remember your mentor, Joe Bajkowski, and my mentor, Joe Bajkowski, used to say that AD, it's not a rash that itches, it's an itch that rashes. I never forget that. So tell me a little bit about that, because we cannot control AD itch with oral antihistamines, right? Why is that?
So it's a fascinating thing because we know that these itch neurons, the inflammatory components. So, right, why is atopic dermatitis so damn itchy? And they talked about psoriasis. Psoriasis is not itchy like atopic dermatitis itchy. That's a whole different discussion. But why is atopic dermatitis? Well, it's because IL-4, IL-13, the cytokines have a direct effect on these itch neurons. So even in the absence of really visible inflammation, these itch neurons are still sensitized. And sensitized itch neuron means a stimulus that normally wouldn't be itchy becomes itchy. And so the classic study that they would do is if you take a tiny little electrified wire and you touch it to somebody's skin who doesn't have atopic dermatitis, they go, ow. If you touch it to the skin of somebody who has atopic dermatitis, they go, oh, that's so itchy. So it takes non-itchy stimuli, starts to make them itchy. And then whenever those itch neurons get activated, the intensity of activation is about the frequency of the action potentials. Well, instead of firing like this, once they get IL-4 and IL-31, IL-13 on them, when they get activated, they fire like this. And so the itch gets much more intense. And then, of course, that drives scratching, right? Anybody who tries to tell somebody, don't scratch, that's just dumb, because the neuroimaging has shown that scratching an itch activates the same parts of your brain that drugs or sex or gambling activate. And so trying to tell somebody who's itchy to not scratch, it's almost the equivalent of trying to tell somebody who's got a cough, just don't cough, just hold it in. Well, it's a reflex. You can't, right? So it's our job to make the itch go away. And the itch isn't mediated by histamine. It's mediated by proteases, by these cytokines increasing the itch sensitization, you know, the environmental triggers directly. It's not mediated by histamine.
So that was great. Unfortunately, we're over time. I thank you so much. I always learn something new when I listen to you, and I appreciate all the info. I'd like to thank our supporter for tonight, Incyte, and hopefully I'll get to see you next week at Fall Clinical if I can go through the customs and immigration.
Good luck, Leon. Good luck. If you need a character reference, you can have him call me.
That's great. Thanks, Matt. So I'd like to thank everyone, and I wish you good night. And please join us on our next session of IDEF Educational Series webinars. Our guest will be Ted Lane. I thank you very much and have a good night. Bye-bye.